All right, so pediatrics is kind of brutal, so be prepared. It's like 168 slides or some stupid thing. No big deal. Crybabies. All right, so a lot of this is A&P review, okay? So we're going to kind of work through this somewhat quickly so we can get to the specifics of diseases and stuff that goes along with pediatrics. So remember way back in lifespan development, right, how important this stuff was? Great. So don't worry about it. Here's the stuff that's important. We used to have this saying that infants were just little adults, okay? We didn't realize how wrong we truly were, okay? Their body structures work totally different. The way disease pathogens work are totally different. There's a lot of differences, and we're going to talk about airway being one of the bigger ones, okay? In this picture, what's the problem? What about it? It's out of line. How do you fix the problem? Pad under the shoulders, okay? Now, this is a little exaggerated, right? But I will tell you an infant would lay just like this. A kid his size would most likely, as long as he's got the conscious ability to do so, would fix his own airway, right? But an infant would tend to lay just like this without padding underneath the shoulders, okay? They belong in the neutral position. Keep that in mind. Their head, right, proportionally larger and heavier than adults until about the age 4, and then we start to kind of balance out when it comes to weight, okay? Always think of an injury that is neck-related or head-related with mechanisms injury, okay? Always think about head and neck in kids. We talked about fontanelles, right, those soft spots, those anterior and posterior fontanelles. What are a couple of things that we use those to assess for? Dehydration. Intracranial pressure, perfect, okay? Airway and respiratory system, the mouth and nose are smaller, right? The tongue takes up more space. They're typically nose breathers, which is why stuffy noses can be more serious in kids than they are in adults. And then their trachea, right? That windpipe is softer and more flexible, so you can hyperextend it the wrong direction, okay? I'm going to go back just a second. You head tilt chin lift this too far, and you can cause an airway obstruction just like not head tilt chin lift far enough. Make sense? Chest wall is softer, right? The diaphragm is more involved in breathing. The thorax is shorter and located adjacent to a very full abdominal cavity. Their organs sit higher up than we think they do, right? So chest trauma is a little bit more critical. And also think about the fact that if you're looking at a baby, you're only talking about trauma that's being displaced over an area that big, right? So a blow to the chest, that dispersing of energy, can cause some pretty nasty injuries to the internal organs. So neonatal ribs are more box-like. They really don't have that curvature like we think of that barrel like we have as adults. The other ones is kids' ribs don't normally break, right? We don't hear about broken ribs in kids very often. They actually absorb it, and when they touch an internal organ, God bless you, it actually passes that energy onto the internal organs, right? Our bones are meant to break and disperse the energy in the bone to where kids' bodies tend to pass it on, okay? So even like autoverse pedestrians, we don't see a lot of broken bones because a lot of the times the bones were so flexible they absorb that impact and pass it to the body. The bones didn't break themselves. So we don't perform blind finger sweeps anymore. We used to teach it to people when it comes to choking kids. There's not really a reason why you should blindly be sticking your finger looking for something, right? You see it, great, pull it out. But we don't just stick your finger in there looking for something, okay? We do, we're going to talk about back slaps and chest compressions and so on here in a second, but no more blind finger sweeps. Here's the picture we've seen now 4 or 5 times, right, which is just the one slide we just talked about that is a visual approach. Okay, we talked about them being more elastic, right, and the fact their bones don't break, they actually bend. Infants and children are predominantly abdominal breathers, a lot of abdomen movement when it comes to breathing, and then abdominal organs are less protected because you don't have that big rib cage, right? Those organs tend to take a lot of the blow without the protection of those ribs. Body surface, The big thing with kids to remember is they're more vulnerable to hypothermia, okay? Infants, we talked about on Saturday, what's the number one place they lose most of their heat? Top of their heads, okay? Kind of keep that in mind. Especially with drowning in kids, be thinking about hypothermia. Blood volume, this is the best look at the comparison between an infant, a kid, and an adult when it comes to blood volume, okay? This is all we're dealing with when it comes to trauma when we talk about kids, okay? We still see a lot of trauma in infants. Okay, the most common one is going to be car accidents. Okay, the nice thing is their car seat does a pretty darn good job of protecting them. Okay, I transported a kid when I very first started, ejected out of the front windshield of a car on 395 in the car seat and was non-injured. Right, through the windshield onto the highway, basically not hurt. Right? I don't know, a good one. Yep, it's still good. Car seat was broken, right? But it was the only thing that was wrong with the kid was the fact that the firefighter, who was intelligent, took the baby out of the car seat and was like, you know, bouncing up and down with her because she was crying. And we're like, did C-spine totally leave your thought process? I understand she was in a car seat, great, but pretty sure she was just a projectile out of the car. What's that? Little baby missile. Yeah, no big deal. This is a 60-pound kid, only half of what we have, right? And then, of course, the circulating volume of about 4 liters. We talked about characteristics, right, when they should be talking, when you should be able to talk to them. Again, about that 1 year or 14 months, around there, they start to have that separation anxiety and that fear of strangers. So before that, it's nice for us as EMS providers because we can help out. But pretty much after about the age of a year, those kids don't want to go to anybody but mom or dad, right? If they do want to go to you instead of mom or dad, there should be a little red flag that pops up in your head that something's wrong, okay? Whether the kid's altered because they're sick or they got a fever, or we're going to talk about, sadly, abuse and neglect as we get further into this PowerPoint. Never let the potential of upsetting a child to prevent you from delivering appropriate treatment, right? They're going to cry, okay? If you've got to get them in the ambulance away from mom or dad, then you've got to do it. Make sense? So one of the things that we've worked on is getting better when it comes to transporting patients. We used to have the idea we would just strap the car seat to the stretcher and transport them that way. That's great, except for the circumstances we run into where, A, there is no car seat, right? So now you're worrying about how you're going to transport them. The other side of things is if the car seat has been involved in an automobile crash, the car seat manufacturers don't recommend that you take it out of the car and then put it in another car and attempt to drive it somewhere else, right? Like our kid in the car seat, I wasn't going to take that car seat and attempt to strap the kid back in the car seat and put it on the stretcher. It's all broken, right? If you don't, this is called a PD mate, which is basically just an insert like a car seat has that goes onto the stretcher. If you don't have something like this, you can, in unique circumstances, have someone sit on the stretcher and then hold the small child and buckle them all together onto the stretcher. Make sense? Not a good idea. It's a huge liability, but if it's the only way you got, it's the only way you got. Libby, what did you ask? Nothing? Yeah, if mom or dad's not a problem, right? If you're going to transport them or something along those lines, absolutely. Not really, because if you think about it, I mean, the stretcher is clear over here, right? This only takes, she probably only catches 2 straps. And think about if this would be involved in a collision with those 2 straps, how secure is she? She's not. I will tell you in an adult, what's that? Yeah. Yeah, good call. You might as well just get up there. 40. We'll start at 40 today. Yeah. Yeah. Even adults don't do well with just the 3 straps, right? Even an automobile crash with an ambulance with 3 straps isn't enough. You can't pull a hamstring. He doesn't do real push-ups. Interacting with the pediatric patient, number 1 is make sure they know who you are, right? If parents aren't there, make sure they understand that someone's called mom or dad, okay? Next one is if there's no life-threatening problems, continue at a nice, calm pace. Even if there is a life-threatening problem, still maintain that calm pace, okay? We normally utilize stuffed animals or toys, something along those lines, to help them out. Whether we have them or the fire department has them, or you can grab something from the family or the house is pretty important. Okay? Go ahead, Libby. Anytime if they're old enough to ask you questions, anybody, I usually do the whole, like, damn dyke divert, right? Which is like, I'm only taking care of you. I don't know about mom or dad. I'll send someone to go find out. Right now, my biggest concern is you, right? And that's just kind of that, you know, as much as you can, you just kind of pitch it to the side. I'm not a big fan of telling kids that parents are dead, right? Especially not on scene, right? Thankfully, I haven't had to do that yet, but I would really want to do it in a hospital, probably. A chaplain, someone that knows a hell of a lot more about grieving and how to talk to kids and stuff like that than I do. The big one is when you're talking to these kids, don't stand over them, right? Kneel down to their level. Unless there's an absolute safety concern, there's no reason to be standing and booming over them, right? Kneel down, talk to them, make eye contact. That stuff's all important. Autistic kids. That's the big one. Just because autistic kids are how violent they can be. So you still may keep a somewhat defensive posture with those kids. You could, but kneeling is still the worst place for you, right? Their safety concerns is not necessarily with the kid, but the environment around you, right? Is there a bystander? Is there mom or dad you're concerned about? Is there something? Kneeling is just the worst, like, position you can be in when it comes to safety. Yep. Yeah, you got to sit. To get up to your feet takes time, takes energy. Defensive-wise, I mean, it's pretty easy to kick someone in the head if their head's at foot level. Don't forget to smile, right? That's important. Touch or hold the child's hand or foot. Don't use them without explaining them. This goes as far as blood pressure cuffs, stethoscopes, SpO2s, things along those lines. That's going to be huge. You know, the blood pressure cuff, it gives your arm a big hug. You know, it shouldn't hurt you. If you've got to put it on mom or dad first to make the child know it's not going to hurt them, then fine. The SpO2 is the other one that kind of scares kids just because of the red light. Sometimes they don't understand there's no pain involved. So all this stuff takes a little bit of time to kind of explain. The big one is if you're going to use a glucometer, right? Glucometer and epi are the two times that you're going to purposely inflict pain on a child, right? Glucometer, the lancet doesn't feel very good. On infants, we usually stab them in the heel and not in the finger anyways, right? When you move on to advanced EMT, one of the worst things you will ever do is start a line on a kid, right? It will make you feel like the most horrible human being alive, right? They're screaming, they're yelling, you have mom holding them down, you're holding them down, you're trying to hold an arm or whatever still because you're inflicting pain. Be honest with them, let them know it's going to hurt, you have to do it to help them. Use diversions, have mom or dad talk to them the entire time. All those things will eventually help that kid. Sometimes the pain you're inflicting on the kid, the parents are feeling more than they are, right? Mom or dad gets worked up and kids are feeding off of that. So kind of pay attention to that interaction to see if maybe it's a good idea to kind of separate, you know, get dad out of the room, let mom just be there or vice versa or whatever you need to do to make it work. Adolescent patient, obviously a little more sensitive to the opinions of their peers. Again, they get a little more intimidated by authority. Depression is still common, kind of in that, you know, starting at 11 or 12 years old. Kind of be aware of those things. We're starting to see things that we thought were like a high school injury or a high school problem, seeing it getting younger and younger. Drugs is one of them. The drug guy that comes in and talks to the paramedic program has a junior high kid. That the kid came home, told his dad something that led to an arrest of a kid selling methamphetamine in the junior high, right? Pills are not uncommon in junior highs, right? They're easy to get a hold of. They don't have to go anywhere else but grandma's, you know, medicine cabinet or dad's medicine cabinet, whatever. So we're starting to see more and more stuff that's a little bit scarier when it comes to adolescents. Suicide still plays a small role in that age group. There was just a kid, I can't remember where it was at, I read an article, I think it was today, that was doing the passing out game where you hang yourself until you pass out. He's 11 years old. His mom found him dead in his bedroom, right? That's the stuff we're starting to see. Suicide is not uncommon.
Sean, how's that game played? I don't understand.
Am I going to tell you like step by step of this or what?
I don't understand because like
But they do it from like a low object, like a doorknob with a tie, thinking the fact that when they slump over, that it will release the tension, allow you to come back to consciousness. But if you fall backwards and you sit and you can't touch the ground, you sit there and hang yourself. Yeah, it's like, it would blow, like, well, at 11 years old, I wouldn't quite say Darwinism, but it happened here in Spokane not that long ago. My dad pronounced a kid that was on, I think it was Daymouth Spokane Road, same exact thing, hung himself from a doorknob trying to play this game. 3 buddies watching him and thought he was dinking around and literally let him hang from the doorknob for 4 or 5 minutes, and he was brain dead. 4 to 5 minutes, yeah. 45 minutes is a little excessive. Pick different friends at that point. Yeah. Crazy stuff. 12, I think. I think he was pretty young. More along the lines of adolescence, don't delay evaluation and care because you or the patient might be embarrassed. If you can, have same gender providers take care of the kids, right? Just kind of be aware of that stuff. Treat them with respect. I'm a big fan of, even if the kid can't talk, right, the 1 or 2 year olds, I'll still make eye contact while I'm asking mom or dad questions, right? Look at the kid and be like, hey mom, do they have any allergies? That kid can pick up on the fact that you're talking to them and trying to build that rapport. So I think it's important. You got to get most information mom or dad, but still building that rapport with the kid is pretty important, because there are those circumstances where we're not going to allow mom or dad to ride in our ambulance with us, right? The fire department tends to hose us more times than not, where they say, oh, don't worry, Deer Park Ambulance will let you ride. Now, the choice to let you ride is up to me as the patient provider. If I feel like the kid's too critical and I'm afraid you're going to be a problem, you don't go, right? If I feel like you are a problem in general, you're not going, right? As long as the kid's not critical, you're calm, cool, collected, there's absolute no reason why I don't think you should, that you need to stay here. I'll let you ride in the front seat, right? If I'm really, really laid back and, like, okay, they're not a big deal, as long as the kid's young enough, I'll let you ride in the back of the ambulance, right? But it's patient by patient case whether or not we allow that. It depends. If they're less than a year, I don't really need mom or dad. Mom or dad can sit in the front, right? That age group is the separation anxiety and it's a respiratory problem, I might put mom or dad in the back of the ambulance. It just depends.
What about the opposite, like the car accident and like if a mom and a kid and the mom gets injured and the kid's not, it's like illegal or something to leave the kids, right?
Well, you're not going to leave, not everyone's going to leave, right? Like, we've done it where, like, our duty officers will come get them, or we've had law enforcement transport them, put the car seat in the cop car, and they follow us because we're either going code or we're going, it just depends. You can put them, I've taken and put a car seat in the front seat of an ambulance before, but I think it was like 5 kids, and 2 were injured. Yeah, 2 were injured, mom was injured, so we sent like half with the one ambulance, and then we were just transporting kids. And so we put a car seat on the stretcher, a car seat in the front seat, and put one of the adolescent kids in the jump seat. So it would have to just be a really unique, and we spent like 20 minutes trying to figure out what to do. We'd called other people, can you come get them? And the answer was no and no, and so it was like, well, we got no other option, so I guess we'll just transport them.
If you suspected like abuse,
Mm-hmm.
I
would do everything I possibly can to not let them go, right? We're going to talk about child abuse, and I will tell you, you're never supposed to lie to anybody in this job. I will lie through my teeth to get a parent to let me take their kid to the hospital, right? If I cannot involve law enforcement on scene, I'll do my very, very best not to, right? Because it just becomes a mess. So if I can get them to the hospital and then tell the hospital that this is, or have my driver call the hospital ahead of time and be like, hey, this is, abuse or neglect or whatever, law enforcement meets us at the ER, that's good. But every call will be different with those circumstances, especially abuse. If you can try to leave law enforcement out of it initially, I would recommend that. And like I said, I'll lie to parents all day long. Yep, no big deal. I know kids fall, or I know kids, they always pull stuff off the stove. It happens all the time. Let's just take them to the hospital. Let's get them checked out. Because the second they pick up on the fact that you think this is child abuse, they're not going to let you take the kid. And they have every legal right to do so until law enforcement's involved. right? Once law enforcement gets involved, the kid's going to the hospital, but how long is that going to take? Is that going to take 5 minutes, 10 minutes, 30 minutes, 40 minutes, an hour? I mean, I've been in places in Stevens County where it's a suicide patient and we call for law enforcement. They're 45 minutes to an hour away, right? And you're like, well, guess what? We're just going to go to the hospital. You can meet us there because I'm not going to stand around and wait for you. Libby, go ahead. No. What's that? Either way, just suicide, law enforcement involved. Yeah. If you lie, don't write it down because it didn't happen, right? Yeah. Or because truly, if you think about it, if you're lying to take care of a kid that's been abused, who's your patient? The kid is, right? And your job is to be a patient advocate at all costs, right? So at that point, I don't care what the parent feels. If you want to get offended, fine. At that point, I will tell you that child abuse and neglect is the one thing that usually gets people's blood boiling, right? 2 classes ago, I think, 2 classes or 3 classes, I had a U.S. Marshal guy that sat in because he needed some OTEP. We talked about child abuse, and he's not a small guy, right? Like 9'11", 800 pounds, right? He's a big boy. And in the middle of my lecture, he didn't say anything through most of the lectures, and he stood up and said, "Can I interrupt you?" And I said, "Sure." And he wrote his first and his last name on the board and his personal cell phone number. And he says, "Anybody in this room that comes across child abuse or neglect, you call me, and I'll go park in front of their house, and I'll wait for them to break the law, and then I'll make sure they don't make it to jail." And sat back down. That's all he said. I was like, ooh. Yeah.
And that's the same guy that somebody went for his gun.
Yeah. Yeah. He's pretty intense, bro. Yeah. He's a funny guy. We should get him back in here because he's super funny. You wouldn't realize a cop until he face plants you into the ground.
Don't touch his gun.
Yeah, don't try to take his gun away from him. Reactions when it comes to illness or injury, we talked about this, right? Make sure that you're aware of this still can interfere with patient care, right? Don't let the parent having issues with, you know, what's going on or how serious the injury is or whatever interfere with your care. Pay attention to living conditions, right? Pay attention to food situations. Pay attention to cleanliness of clothes, right? For the first time in my entire career, what was that, 3 weeks ago? 3 weeks ago, I had to call Child Protective Services and report a mom for child neglect, right? Had never done it before, right? Been in lots of houses where, you know, the paramedic might have dealt with it, but it was one of those circumstances we were there for something totally unrelated, right? It was domestic violence. And we walked in this house, and I have yet to see a house that was more disgusting than the one I was in, right? Mm-hmm. And it was hard. Like I spent, the call was at what, 1 in the morning, 2 in the morning, something like that. It is very, very early. So all the way home, I was having this conversation like, so I feel like an absolute monster. Here we have a mom who literally just has her ex-boyfriend break into the house and beat the living tar out of her, right? Punch her in the face, try to hurt her, threaten to hurt the kids, and so on. And now we've transported to the hospital, and now I'm going to call CPS and get her 3 kids taken away, right? So I sat down with Gary here and said, like, you know, where do I stand on this? And he's like, it's your legal obligation. He's like, if you truly feel that the living conditions were that bad, then make the phone call. So I made the phone call, and I had a lot of information, or a lot of answers to the questions the lady was asking, but I didn't have a lot of, there was a group of questions she asked that I didn't have answers to. She was like, well, you know, how much food was in the house? I was like, I have no idea, I didn't look. Right? And she's like, well, how long were you there? And I was like, well, we were there 30, 40 minutes, right? We were waiting for Grandma to get there to take the baby. And she's like, you know, what did the kids' rooms look like? It was like, I don't know, I didn't go down the kids' room. And so she was asking these questions that made me think, if you think this is abuse or neglect, those are the questions that are going to be asked, right? How many kids? What were the living conditions? What was the cleanliness? Was there objects that could harm the kids that they're easily reached? What was the food circumstances? What did the rooms look like? What was the temperature in the room? Was there broken, you know, windows? Was there broken doors? And I had some answers, but there was a lot of questions where I was like, I don't know, I didn't look. 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 Right? Over and over again. And so if you are the first person who calls, if it goes to court, you will be the witness. Right? If you are 2, 3, 4, 5, 6, or 7 that calls, you don't necessarily become a witness. Right? So in our circumstance, I was the first person who called, so they take all your personal information down and determine if you're going to be needed, depending on their investigation. right? It's a long process that I will tell you that I'm not looking forward to ever doing ever again. City.
How do you get to check the fridge and check the pantry?
I stood in the kitchen. I looked in the kitchen. Like, we were just standing around kind of doing nothing, and so I kind of had that idea. I mean, I didn't look. There was a cabinet that was broken open, and so I had, like, looked in the cabinet, but she was like, next time, just, you know, I had enough reason to be like, hey, I'm just going to go check on your kids, make sure they're okay. Could have walked, opened the door to the bedroom, take a look around, and close the door, right? Didn't think about doing it. There's lots of times, diabetics, patients who are unconscious or altered, we look in their fridge to look for medications. We look, I mean, you've got justification to do it. Just in that circumstance, the thought didn't cross our mind.
Well, if you've got, like, the mom in, like, you know, in the kitchen or in the living room having all the kids in there, you don't have reason to be like, I'm going to go check the bedroom real quick.
Yeah. Like I said, in that case, absolutely. But in our case, where 2 kids are sleeping, you know, and this whole process it's 2 in the morning. You know, I could have been like, hey, just want to go check on the kids, make sure they're okay. You know, open the door, take a look in their rooms. I will tell you, having seen like what 75% of the home, I told the lady on the phone, I know exactly what their bedrooms were like because you don't keep 2 clean bedrooms, and the rest of the house looked like it's literally been abandoned for the last year and a half. I mean, I had literally never seen a house so bad. There was exposed floor, there was trash, there was a pocket knife on the floor, there was a big TV that could have been pulled over on top of a kid, there was moldy bowls, there was moldy food. I mean, it was literally the most disgusting thing I've ever seen. Go ahead.
Because at the house, couldn't we, like, in that situation, if the kids weren't sleeping, could we have also said, because it wasn't you, we knew he was locked up, we could have also said, oh, could we go check to make sure ours were safe or something like that?
Yeah, but we knew he was under arrest. So he was already locked up in a car, so we're kind of hosed.
Yeah.
Libby, go ahead. If you think it, raise your hand. Let's see here. Notice this is pretty unlikely, right? We talked about using blow-by for kids. I have yet to see a kid that's not super sick that will just take a non-rebreather, right? If they allow you to do this, we start being concerned that they're lethargic, they're really, really sick, and they're probably more critical than we think. What's that? Yeah, unless she's super sick, then she might just lay there. I would assume, since these pictures are all taken by Dan Limmer and they're all staged, this is probably mom and dad, right? So you can probably convince that girl with mom or dad to do it, but it's pretty unlikely. So one of the things in your textbook that I will encourage you to make sure you know is the pediatric assessment triangle, right? You'll hear us most likely say PAT on a regular basis, okay? The PAT is a little bit modified from A, B, and C, okay? It's a triangle that's got 3 sides, right? It's kind of like this Cushing's triad or something along those lines. The 3 sides is appearance, work of breathing, and circulation to skin, okay? How long do you think it takes you to assess those 3 things on a kid? What do you think? It takes you 30 seconds to get those 3 things? How about 15 seconds? How about 5 seconds? Right? It happens I would say within about 5 to 10 seconds, you have a pretty good idea, right? Do they make eye contact? Are they in a position that would indicate difficulty breathing? What color are they? Yeah, a breath or 2, just to kind of see what we're looking at, right? So we call this sick or not sick, right? In kids, your general impression, the 2 questions I want you to answer, or the one question is this kid sick or not sick, right? Sick means you anticipate them to be critical. Not sick means you don't think they're critical, okay? It doesn't mean I'm transporting or not transporting. It's just a 10 to 15 second look at, do I think this kid's critical right now? Can kids that you deem not sick become sick? Yes, and vice versa, okay? So do it from the doorway, right? The second you see the kid, put that sick or not sick in your head, and then, of course, through your assessment, work on that sick or not sick from there. Okay, scene size up wise, safety is still your concern, right? Pay attention to parents, pay attention to bystanders, pay attention to surroundings around you. It's easy to get tunnel vision with kids, right? Kids normally raise your adrenaline level no matter what the call is, right? Just because it's a kid automatically makes you start getting a little bit amped up. Don't let that mean that you miss something that's a danger to you. Okay? It's a really horrible, horrible picture. But that's the pediatric assessment triangle. True story. You're killing me. So, we still care about airway, right? We still care about providing oxygen. A kid this size, the best you're going to do is blow by, right? Why do you not put 15 liters non-rebreather in a kid's face? It's like 9 answers, so let's try that again. What? They might panic. What else did you hear say? So it might cover their whole face. There's pediatric non-rebreathers, though. What else? They might freak out, might suffocate them. What else? They might not breathe enough. How many of you have ever been around a kid, a baby, right? How many of you are blown in their face? What do? They hold their breath, right? That's how you teach kids to swim, is you blow in their face and dunk them underwater, right? You don't hold them underwater. You just dunk them, right? They have a reflex that when kids are screaming, if you blow in their face, they hold their breath. So 15 liters non-rebreather will be enough to make them hold their breath, okay? That's why it's called blow by, not blow at, right? Blow it in front of their face, not into their face, okay? Form your abdominal impression, which we talked about. It's all basically the same when it comes to PAT. Okay, make the observations. How are their response to you? What's the tone and position of their body? What's their work of breathing? All that stuff's going to be important. Okay, mental status. You still go through the same process. Now, painful stimuli is slightly different in pediatrics. Okay, we don't sternum rub babies. Okay, flick a heel, pinch a nail bed, something like that, but don't sternum rub kids. Good way to get you fired. Yeah. Wake up. Assess the airway, right? Kids are more susceptible to those airway problems, so make sure that positioning is big, right? Looking for, I guess it's farther away than I thought. Make sure you pat underneath the shoulders. Okay? Altered mental status is still your number one indication that hypoxia can be a problem. Okay? If a kid is in cardiac arrest, what body system is most likely the cause? Respiratory. 99.9% of the time. Okay? If it is cardiac, it's a congenital defect. It's not CHF, it's not an MI, it's not stuff like that. Right? Kids, number one cause of cardiac arrest is respiratory problems. Okay? If you see a test question, keep that in mind. Okay?
And your 9-year-old doesn't have a large chance of throwing the old tombstone heat wave.
9-year-old maybe, right? Because I pronounced a 12-year-old dead that had an MI in an all-night track event. Right? It can happen. It's just very, very, very rare. Okay? Assessing breathing, still nothing different there. Can you listen to lung sounds on a kid? Do. Right? Skin color, cap refill. Cap refill in infants and children younger than the age of 5 can kind of take place of your blood pressure. Okay? You can get a blood pressure on a 5-year-old, but a 3-year-old, you're probably just going to do cap refill. Okay? You can do a blood pressure on a kid. It's just not, we don't do them very often.
One of my buddies just got on like the ER, and he was talking about taking BP on kids, and he said
the thigh.
He said take him on the calf.
The calf, yeah. You can thigh cuff them or calf cuff them. It's the same. The cuff goes, there's no different, right? It still goes either above the knee or below the knee. You're turning the cuff, the arrow for the artery at the kneecap, right? That's where it needs to go. So on the thigh, you want the arrow down towards the kneecap, and on the calf, you want it up towards the kneecap. Right at the kneecap, because that's where that artery is that runs from the femoral behind your knee down to their foot.
And if you're checking it on the calf, would it be on the...
You're taking the cuff and flipping it upside down. Same thing, and the kneecap. Yeah, you can do it on the top of the foot, but I would do it on the kneecap. I'd flip the cuff upside down. Yeah, behind the kneecap. Yeah, not here, obviously, but here, right? You can do it dorsal. Their peripheral pulses are almost non-existent. It's why kids' hands are almost always blue and cold. It's because there's not a lot of blood flow getting their fingertips and their feet, right? It's just not going that far. They don't have enough blood volume to push blood all the way down that far, right? A 4-year-old, a 5-year-old, take a blood pressure in a normal spot. On an infant, if you need a blood pressure, you can go with one of those, right? I've never taken a blood pressure in a kid less than the age of 5, right? But I haven't had, without a paramedic, I haven't had a lot of critical kids, right? So cap refill works pretty well. Priority patients. So a pediatric patient, if one of the 3 pieces of that triangle are abnormal, they're critical. Okay? So if appearance is off, or work of breathing is off, or circulation to skin is off, they're sick. Okay? If the patient is listless or unresponsive, just like an adult, does not recognize the parent or primary caregiver, right? If they have no attachment to them, your concern is there something wrong with that kid? Okay? If they can't be consoled or comforted by mom or dad or parent or, guardian, something like that, that should also raise a little red flag. To me, this is more of my concern for like abuse and neglect in some circumstances than the medical side. Yeah. If they're like crying and screaming and mom or dad can't console them, that's probably more of a pain response or something like that. But if they're, you give them to mom or dad and they're thrashing around and trying to get away from mom or dad, my concern is still more on the lines of like abuse or neglect.
If they don't collect that their mom is a safety or anything like that, would you also think autism?
You can, but we're never going to diagnose that in the field, right? It's impossible. Normally, autistic kids build the bonds that they've known. So as long as they've had mom or dad their whole lives, they usually will make that bond, right?
I like nanny for the kid, and his mom was his primary everything. Like his mom and grandma was the one who took care of him.
Right.
But whenever his mom would leave, he wouldn't pay attention to it.
Right.
He wasn't that like, or he only had Asperger's. He wasn't like severely autistic, but he,
Yeah.
mom left him is fine.
We're pretty poorly trained when it comes to autism, right? That's why the Isaac Foundation is now building a program to teach EMS providers how to deal with autistic kids. I think Thursday we'll talk about autism in kids, and it's half a slide. And it's be careful, they can be dangerous. And like that's literally all we talk about. We don't talk about how to console them, how to take care of them, how to restrain them, because you're probably going to have to, what's safe, what's unsafe. They don't talk about any of that stuff, just because we basically been pretty ill prepared up to this point. I transported 1 kid with autism. We have 1 special facility in Deer Park that deals with mentally delayed adults. We see more Down syndrome than we see with autistic kids, or even adults. We see more of the Down syndrome stuff with adults. And even they can be violent in some circumstances. They get sick, they get scared, they can have issues. Most of the mentally delayed adults we've dealt with, if you just talk to them and remain calm, they're really, really easy to deal with. Compromised airway, this stuff is no different than adults, right? Compromised airway, respiratory arrest, shock, uncontrolled bleeding, all that stuff, like I said, is no different than what it is with adults. What do you think of this kid? Sick or not sick? Why? So he's supine, but you put him there. You wanted to put that kid in that picture, flat and supine in a stretcher, right? What's normal for the most part. What else do you think? He is just laying there. I like that. Now, take a few seconds and take in everything in this picture and tell me if you change your mind. So what does that mean? Nothing. Right? Because it might be that ambulance agency's policy that you have to take parents. He's looking at mom. Right? He is just laying there. It's a still picture. Right? It's a moment of time. Right? But look where he's looking, though. You're right. He is just laying there, and he's got a weird posture. But is he looking at mom? Maybe. Is he seizing? Potentially. See? The still picture is totally misleading. Your initial reaction is he's sick. But I could argue that he's looking at mom. Now, my other concern, and I can play devil's advocate, is mom seems fairly calm, cool, collected, and doesn't care. Now, it's a still picture. Is she dialing dad to say they're going to the hospital, or has she been on her phone for the entire transport? Right? Those are the silly things you got to pick up on. Okay? What does the paramedic or EMT or ambulance driver, whatever this guy says he is, what do you think he's doing? What does he have in his hand? Let me know. It's a measuring tape, but it's a special type of measuring tape. It's called a, no one?
The kids measure it, we just got them, I just saw them.
Yeah, Broslow tape. Okay? So what it is, and I've got one, I'll go, at break I'll go get one. It's a measuring tape that has colored boxes that are, it's based on length. It's a length-based tape. Okay? So you put it at their head and go to their feet, and it puts them in a color, right? You can kind of see the colors right here at the top. So this kid's yellow. In the yellow box, it will tell you that roughly this kid should be 12 kilograms, right? And then it will tell you exactly the dose for dopamine, epi, lidocaine, the ET tube size, the King Air size, what's their normal blood pressure supposed to be, heart rate, respiratory rate, saturate, everything, basically. Now, remember the PowerPoint I showed you with, for my dad at MedStar, the pediatric bag that had the colored pouches? Those colored pouches are pre-filled drugs with those colors. They're already pre-filled. So if it's yellow, you open the yellow package, and it's already all pre-filled right to the right doses. It has that size ET tube. It has that size OPA, that size NPA. Everything's all pre-done, right? Broslow tapes are pretty cool, right? They do really, really well, as long as you remember to use them, right? Because it'll tell you normal vital sign ranges, all kinds of stuff. With pediatrics, if you're talking to the kids specifically, make sure you use simple questions that cannot be answered with yes or no. You still want to know a better answer than yes or no, but make it nice and simple, right? Any assessment you're going to do, make sure you explain to them, especially when it comes to cutting clothes or immobilizing a broken extremity or a possibly broken extremity. Make sure you take and record vital signs just like always. Textbook and NREMT is going to say anything over, anything under the age of 3, we're not taking blood pressures. Okay? Physical exam, this one's unique. They recommend that you start at the toes and work your way towards the head to gain patient rapport. It's in red because I know there's an NREMT test question that hoses people. Okay? There's no injuries. They should be held in the parent's lap as long as your ambulance will safely do so. Do your very best, protect the child's modesty so that way you don't cause embarrassment or cause them to start having anxiety or something along those lines. Anytime you have to remove a piece of clothing, you should explain to the patient why that is. Make sense? Are you getting the hint that everything you do, you have to explain more in depth? Right? That's the biggest thing when it comes to kids. Assessment of the head, don't apply direct pressure with a fontanelle, right? Put your hand and feel, but you're not going to try to push the bulging fontanelle back into the head. Okay? Meningitis and hand trauma can cause bulging of fontanelles. We're talking about increased cranial pressure on that one. Collisions can often produce head injuries. That's probably one of the most common areas we see is head and neck still in car seats, right? Especially if the parent has flipped them to forward-facing before they should be, right? Because a lot of accidents occur head-on, and if the kid is rear-facing, it has all the support it needs, right? Because the transfer energy, the body wants to go forward, but if they're rear-facing, that means they're then laying against a hard surface. If they're forward-facing, their head then tendency to flip forward, and their body stays in position with those straps, okay? Nose and ears, still going to look for fluid, still going to check for blood, still going to look for skull fractures. This is blow-by. You can use blow-by with just oxygen tubing, or you can utilize a non-rebreather if you need to. Neck, still vulnerable to spinal injuries. We talked about them having proportionally larger and heavier heads. Again, if they're crying and screaming because their head's moving around or something like that, be concerned that they probably have some pain or tenderness with when it comes to their neck or their head. There's the pad we talked about. This pad's a little bit long, right? We only need to catch just the shoulder blades, right? But if it's a big blanket or a big towel, you're going to have to utilize it. You don't want to build it too much up. Only talking about 2 to 3 inches is all you need, okay? Just enough to bring that chest cavity up to put this head in the position it belongs.
Sean, you spelled it wrong.
Couldn't help it, or what?
40?
50. airway, maintain neutral position for infants. We talked about sniffing position or neutral position. I'm going to try to get through all the stuff that's in red before my happy gets a chance to take notes. For the chest, make sure you check to make sure it's symmetrical. Make sure you look for bruising. Still going to look for paradoxical motion or retractions, just like adults. Nothing really changes. Abdomen, still assess it, right? Nothing really changes. Pelvis, check for stability. Extremities, cap refill is important. You're going to look for distal pulses. Expect them to be weak in smaller kids. Okay? And then we talked about PMS and CMS. The first 5 were crappy push-ups. By the time this class is over, you will have done 50 good push-ups. Reassess, it's the same thing, right? Airway, breathing, circulation, general impression, put your hand down. Monitor breathing, monitor airway, all the stuff's the same. No? 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 Reassess every 5 minutes for unstable patients, every 15 minutes for stable patients. Sucks the two people, the person to your right and the person to your left don't take notes. Ensure the appropriate treatment and care was given to your patient. Okay? Let's take a break right there.